I really wanted to focus on 3 cases that I really struggle with athletes. The first one is just the standard run-of-the-mill axial low back pain. It's very common in just the general population, but it gets a little more difficult in athletes, especially as they're trying to progress to the next level, progress through a series of exercise, perhaps through an injury, and it's just low back pain. So moving to the second case is leg pain. So that's a pinched nerve in the back commonly, and so that gets a little bit difficult with athletes because they're very keen on getting back to play, and we know that if you leave those patients alone in a year, if you manage them non-operatively, they're just as good as the operative group at a year. The unfortunate thing with athletes is they're oftentimes wanting to get back to play. So that is a little bit different of a paradigm shift from a surgical standpoint, because oftentimes we'll try to drag our feet as long as we can before we operate on a herniated disc. With athletes, it's a little different because they want to get back to play. Then it becomes, is it a high school athlete or professional athlete? The professional athlete oftentimes will get surgery maybe a little bit quicker because they need to get back to work. Whereas the high school athlete, it becomes a little bit more of a heart-to-heart with patient's parents about what's best for kid, and so that's a little bit different. And then finally is what to do with a slip or a spondylolisthesis, not uncommon congenitally, and then it's a problem for the female athlete, the bending backward athlete. So that's going to be the gymnastic, usually female. It's gymnastics as a kid. And then for men, it's usually with wrestling, but it can be from any of those. I'll kind of gloss over kind of the rehab stuff. We have good speakers on that today, and kind of focus more about my surgical decision making in the athlete in general. 3 parts of the cervical spine: cervical, thoracic, and lumbar. 7 cervical vertebral bodies, 12 thoracic, 5, sometimes 6 lumbar. Just the terms, what we mean, what I found working with our physical therapists and athletic trainers is oftentimes we talk a little bit differently. So from a stenosis standpoint, it just means narrowing. And in the spine, and so this would be an axial cut through the spine, there's really 3 different places where the spine can be narrowed. Right in the middle, and that would be central stenosis. Out in the lateral recess or the sides of the central part of the canal, which would be lateral recess, and then foraminal stenosis. And those are the 3 different spots that nerves will get pinched. And then radiculopathy, pinched nerve. And you can get it in the arm, you can get it in the leg. Very classically, if somebody has a pinched nerve in their leg, in their arm, if you just ask them to draw it, I found over the years, if you ask them to describe it, very difficult, sometimes vague. Pain can be hard in terms of, but they very consistently will always draw you a pattern. So I've honestly stopped asking them. I ask them kind of for a little bit, I'll let them fumble with the answer, and then I'll just say, can you just take your hand and draw where your pain is at? And they'll very subconsciously almost draw out a very typical pattern of what you'd expect that pinched nerve to be, whether it was in the cervical spine or the lumbar spine. But this is a collegiate picture, increasing low back pain for 2 years with pitching, associated with intermittent right greater than left leg L5 distribution numbness, denies any weakness, denies any changes in bowel or bladder. On exam, tenderness, and then full strength. Here's the x-rays, so AP and lateral x-rays. 5 vertebral bodies, numbered 1 through 5. And you can see that the L5-S1 level looks a little degenerative. As we age, this is a very common disc to degenerate. Every bone takes up the weight of the one before, so it's very common for this to be a degenerative disc. In the 20s, though, it's a little odd for this to be degenerative this bad. So I would say degenerative disc disease at L5-S1, more than appropriate for age, and then some of the joints in the back, the facet joints are degenerative as well. They just don't look as clean and crisp, and so I'd say facet arthropathy. But no instability on flexion extension, and that's what I really like about the x-rays in the young patient or the athlete, is determining whether or not they're formally unstable. We'll give them a few millimeters of motion, and we'll call that physiologic, but nobody should really move more than about 3. For axial low back pain, usually we don't jump to an MRI, but when they get to me, I usually have one or I get one. What I'm looking for on the MRI is I'm looking for a pinched nerve. Sometimes a subtly L5 or S1 pinched nerve can manifest itself as back pain. Going up from there, though, decompressing that nerve doesn't always work. So I tread very lightly on that finding without it going all the way to the foot in terms of operating on people, but just knowing that a subtle pinched nerve. I'm not sure why that is in terms of why does it zing all the way to the leg. I think it's because the nerve to the facet complex, so as the nerve exits, it wings back around and gets the facet complex. I think that nerve can get irritated, either from facet degenerative changes, irritation, or it can be pinched and irritated. I'm not sure, but we tread lightly from a surgical standpoint on decompressing nerves in the setting of back pain only. So what actually hurts? Well, after talking with Mike Baer about this over the years, it turns out that I very quickly am very uneducated about the muscles and the facet complexes in the back. We get so focused as we move along in our education, and I think we forget those things that you had to study when you were going through school, and then you tend to forget those things if you're just not using them on a daily basis. I tend to focus on things I can fix, so I can fix herniated discs, I can fix instability. So I'm not as astute in terms of knowing the small muscles in the back, but I know where the nerve endings are. They're in the muscle, they're in around the facet complex, they're in around the disc space, and then they're in around the periosteum or the bone itself. And trying to figure out which one of those is actually the pain generator, I haven't found a good mechanism for. I think the best thing is feeling their back and having them point to where they hurt, because a lot of people will tell you their back hurts, and it turns out that it's their SI joint. The other thing is that if you feel their back and it feels just a little off midline, it feels like a facet complex, I think that's probably facet. In terms of kind of walking them through what hurts, what makes it hurt, what doesn't make it hurt, I think the mechanical loading, makes sense to me that that's either a disc or facet complex, whereas if it's just present all the time, I'm not sure what to make of that. Like the person that's having a heart attack, the left arm hurts. The left arm is fine. It's their heart that's the problem. And I think back pain is kind of a similar phenomena. The whole thing hurts. I can't tell you where the pain generator site is. And so that becomes very difficult for patients in terms of understanding, because they want an answer. And it becomes frustrating for us as well, because we don't necessarily have an answer. The good news is that usually back pain is very limited, and it can get better in time. For most patients, it's about 3 months, 3 to 6. For young athletes, it's a little quicker. The caveat to that is if they're trying to push their way through an injury, they can continue to kind of get in this cycle where they're re-injuring it slightly. So those people, we try to maybe pull back a little bit. But you're all keenly aware of the therapeutic modalities for the non-pharmacological or non-medical management, non-medicine management of low back pain. We have good evidence that these things really work. In the athlete, it comes a little bit more complicated because they're oftentimes anxious to get back to play. So when they get to me, they've usually been through the whole ringer, and at this point, what do I do with them, knowing that from an operative standpoint, I don't have a great answer for them in terms of looking at me and say, I'm going to do this surgery on you and you're going to feel fantastic from fixing your low back pain. I can fix a herniated disc in terms of unpinching that nerve. Those patients will get better. If they have a spondylolisthesis that we'll talk about, we can fix that, but the results of that are mixed. So for just back pain only in the young person, I do two things. I'll get this CT SPECT scan. It's a CT scan which will give you really good bone anatomy, and at this point, usually the first line is always an MRI. It'll miss a subtle pars fracture. So oftentimes if it's your bending athlete, the wrestler, the gymnast, the football player that's had an injury maybe before in Pop Warner even, it's very subtle that you can miss a pars fracture. So I like the CT SPECT for getting a small, subtle fracture at the facet complex of the pars, which connects the two facets together and prevents that translation. I like that to rule that out. The second thing is it's a radioactive study. I maybe don't get it for the kids as often, but what it is a radioactive phosphate group. Bone is calcium phosphate. We know that arthritis is a great arthritis scan. A spectroscopy scan is a great arthritis scan. So we infuse a radioactive phosphate group. It circulates in your body for a couple hours, and then we put you under a fancy Geiger counter. We take that fancy Geiger counter, which shows you these hot spots that you can see, and we marry that with the CT scan. So the SPECT aspect will give us definition of where the arthritis is or where the bone turnover is, and the CT scan will localize where that's at. And so what I'm looking for is I'm looking for it to localize to a specific facet complex or an end plate, and then at least we feel like we're a little smarter about directing care that way. The problem is when you hurt right in the middle, you can be 1 level up, 2 levels up, 1 level down, 2 levels down, and you really don't know. So I find this helpful in those very difficult cases. If it shows one place is hot, at least we think we're on the right track in focusing therapy there. Maybe we can get an injection for a steroid injection. Maybe we can start laying off some of the lateral bending exercises if it's lighting up like that. More, it's just making sure we're not missing anything. And then, then I'll run through the arthritis scan. So oftentimes ankylosing spondylitis, which is a hereditary disease or can be sporadic, it can manifest that in the young patient as low back pain. So I'll get an HLA-B27 marker, which doesn't mean they have ankylosing spondylitis, but at least it's a marker for possibly later on the development. Then if it is positive, I refer them on to a rheumatologist. A rheumatologist, they change the criteria for that diagnosis. It seems like every about 5 to 10 years. But usually it's a diagnosis of, you have to have 3 of 5 things. That's usually things like sacroiliitis, another joint that is also bothersome, a shoulder, a hip, elevated markers, family history. And so the diagnosis of ankylosing spondylitis is a set of criteria that you have to send them to a rheumatologist for, and the HLA-B27 marker is the first step in that, but it doesn't mean that they have it. If they do have it, it means that they need to commit to really a lifetimes of some type of exercise that maintains stability and strength of their joints. They're gonna hurt, they're gonna have arthritis as they get older, but things like swimming, yoga, developing long, lean, stretchable muscles to support, they'll do better than if they don't. They're going to hurt either way though. If they don't move, they'll hurt. If they move too much, they hurt. It's a tough one for them. Most of them fortunately improve over time. And in the case of the HLB27, I try to get them in the right direction in terms of getting to a rheumatologist. Herniated disc is almost a little bit nicer for me because at least we have something very defined that we can point to and say this is why it hurts. So 22-year-old runner, increasing leg pain after running for about greater than 5 miles. He's training for a marathon. Up to about 4 miles, he's fine. Then for some reason, just after 5, he just starts getting this pain down his leg. And then he has dorsiflexion weakness. Here's his MRI. So on the left, it's a T2 sagittal MRI. I like this particular view because it shows the cerebral spinal fluid as white. And so looking at the spine from the side, the bones in the back stack up on one of like building blocks, so L5, L4, L3, L2 with a disc in between each one. And you can see the disc between L4 and L5, the L4-5 disc, has this large herniation posteriorly, and you can actually make out the nerves as they traverse the central canal, and you can see this one draped up and over. Here's an axial cut, which shows it's a little backwards. The Germans, when they first invented MRI, envisioned the patient being sliced from the foot towards the head. So the right's always going to be opposite you on the scan. So like on this particular side, the disc is actually on the right side, which is a little counterintuitive. If you just look at the scan, you say, oh no, that's a left side, it's a right-sided disc. So herniated disc on the right, it fits what they're complaining of. We've done good studies looking at this. So it turns out if you flip a coin and you randomize patients to either a non-surgical or a surgical group, they're both happy. 90% are going to be better at a year, and they're both happy at a year. The tough it out group, they're definitely in misery for a longer period of time, and that becomes a little bit of an issue with athletes because they want to get back to play. So I tend to find myself operating on that athlete that's dependent upon maybe for their livelihood and they're truly held up. It gets a little bit more sticky if it's the high school athlete, if they're wanting to get back to play in terms of operating on them. The real issue is long-term, you have to take some of the facet complex. We know that we get away with taking about 1/3 of the facet complex most of the time. 80% of the time we get away with taking 1/3 of the facet complex, but 20% of the time we don't. And what that means is 10, 20, 30 years later, they start to develop a little instability at that level that may require a fusion. So that's really, I think, the big risk long-term in the young patient is going forward. It sets them up about 20% of the time for perhaps another fusion down the road. But these are all the different things that they can try. I encourage people to try them before considering surgery if they can. The reason to do surgery up front really is for incapacitating pain or patient preference. Unfortunately, nobody has to live with their pain but them, so it becomes their preference. A little bit of weakness I'll live with because that'll get better. As you know, we all have seen that weakness get better with physical therapy and time. A little bit of weakness I'll leave it, and then if it's any bowel or bladder problems, that's an emergency. Or increasing weakness and it's just they're not getting better with time, we'll jump in on that. And then any pain that lasts for longer, about 2 to 3 months, at that point it's probably time to do something different. And that something different Oftentimes it's surprising that they haven't tried other things first, and so they got to start with that. But that's when I start thinking that surgery is okay in these particular patients. So the way we do that surgery is we operate through a small incision in the back. We go down through the muscle. I split it with a tube, and then I look through a microscope. I have to Dremel off a portion of that facet complex to get down next to the nerve. You gently pull that nerve aside, and you just take out that portion of the disc that's herniated. We used to try to take out the whole disc to prevent a disc recurrence, which is 10%. What we were doing was we were giving people a ton of back pain by scraping their disc out, and we weren't decreasing our incidence of having another piece pop out. So really we should call this surgery a fragmentectomy or a fragment removal. We shouldn't really call it a discectomy. You take out that piece of the disc. You can't really look too far because you have these cables in there that are limiting you, the nerve roots, and you can only stretch them so far. So we are limited in the window that we can look, but we do feel around, sweep around, looking for another piece that's about ready to pop out. We try to grab it at the same time. But the recurrence rate is 10%, and it's an outpatient surgery. It's a good surgery in terms of relieving their pain, but that study would suggest that if they were to tough it out, they would be the same at a year. So the nice thing about doctors and studies is that depending on if you're a surgeon or a medical physician, you'll interpret that study two different ways. So that study was done, and when they flipped the coin, the purist would say if you were randomized to the non-operative group, no matter where you were at in a year, that's where you were analyzed finally. Well, some of those patients jumped over to the surgical group. So the surgeon said, well, you really can't go head to head if 20% of your randomized non-surgical patients are jumping over to the surgical arm, and then vice versa. So if you look at that study as treated study, it turns out that the surgical group perhaps did a little better. So you can take that as you may. I kind of give both patients both views. As a surgeon, I think, if it was me, if it was my kid, I would see if I could tough it out for about 2 months, 2 to 3 months, and if it's just not getting better, I'd get my surgery. I'd get my surgery earlier if I was just hobbling around and was just miserable and really couldn't get back to work or back to play. 85 will improve in 6 weeks, and then we kind of went over what I offered discectomy for. Back pain surgeries don't often work unless there's a structural problem, which brings us to our next case, spondylolisthesis. So this is a footballer from Hermiston, Oregon, linebacker, wrestler. He's a heavyweight. As a sophomore, he developed new onset low back pain after getting folded in half. And that's oftentimes what I'll see with the footballers is that it's this folded backward tackle. It's kind of this grabbed low and then tackled high at the same time. They just get folded. Usually it's a folded backwards, not a forwards. So I think what happens is they just take those pars and they offset and break them. They're so tough, though, and their abdominal musculature is so tough, I think, in some of these patients, that they just get through it. And he only had pain for about 2 weeks. He returned to play, and he'd have kind of this intermittent low back pain with some loading, but did well until his junior year. And as soon as he started playing football again, he had a lot of back pain with attacking, and then he had some intermittent numbness in his S1 distribution with loading. Hitting the tackle sled would get him, and then any kind of contact in practice. Amazingly, he denied any leg pain. He did have some numbness and tingling, which is missed there, and then no loss of bowel and bladder, which is a big one. Loss of bowel and bladder, just send them to the emergency department. That's a neurosurgical emergency. We're looking for a big herniated disc to take out. So cauda equina, which is a muscle weakness, saddle anesthesia, and then loss of bowel and bladder. On exam, he was tender in his low lumbar spine, but no, specifically, I look for SI joint tenderness, which is just, you've seen it, it's tenderness off midline, just right about where you think that SI joint would be. And then I also test the hips. Hips can, I think, refer some pain. This is oftentimes a very gray zone. So I'll palpate their trochanters, I'll palpate their hips, and then I'll range their hips as well. And he ranged fine. But this is his X-ray, X-ray and CT scan. He did have a CT scan. So X-ray on the left is the lateral radiograph. Looking at L5S1, it shows some degenerative changes, and then he has a slip here. You can make out that it just doesn't quite line up as well on the other. The CT scan shows a little better. He's offset here. It's graded, there's 4 grades, 25%, up to 25% is a level 1, 2 is 50%, less than 50% is 2, less than 75% is a grade 3, and then more is a grade 4. So he's a grade 1, almost 2 spondylolisthesis, and then his MRI is there. So why these can happen congenital, it turns out that they can run in families. Eskimos in Alaska have a higher incidence of congenital pars defects at L5. There are some families in France. They can run in families otherwise, and then oftentimes there's a history of some kind of backward bending exercise in the young growing spine is I think what gets it. So gymnasts as girls or males even, and then wrestling as males, but probably going to become more confident as we have more female wrestlers as well. We just covered the Oregon State wrestlers, trainers, and we're just seeing more female athletes that are wrestling nowadays. So I suspect that there'll be a setup for this as well. If it is from a fracture, oftentimes there'll be some kind of history where a period in their time, fall out of a tree, trampoline are the big ones, less than 12, and their parent will like, yeah, you know, you did kind of hobble around for about a week. And you would think they'd hobble around more if they broke their back, but it's just a week. And then over the age of about 12, it's usually some kind of folding thing. In footballers, it's that folding tackle. And then in other athletes, I've seen motocrossers who've been in bad and they hit their butt hard and they fold forward, and I've seen it do that too. So it can go either way. It can be an extreme flexion. I've seen usually extreme extension. And then as you get older, it's degenerative. The thing that gets people in the end, though, is if it starts pinching the nerve. And so this is a nice example. Here's a pictogram of the pars on the side where it's fractured. And as that vertebral body slides forward on the other one, it starts dragging that nerve with it. And the foramina on the side are dependent upon the alignment of the spine itself. So as that vertebral body drags forward, that foramina gets smaller. So what gets a lot of people is just leg pain, which we can fix. Back pain's a little bit different. I encourage people to start with just the standard, really abdominal strengthening. So what people who can take a little weight off and get their core strong, I've seen them beat it. So who have I seen beat it over the years? Athletes who are able to do that, they have to tailor some of the things that they do, and then oftentimes they don't progress to the next level, collegiate level. And so the other ones, dock workers in Longview, I've seen 2 or 3 of them now beat it, and what they've done is basically do everything that we tell them not to do, go back to the gym and lift weights. And so if you ask them, though, what they did is they went on some crazy diet and lost some weights. And whether it's paleo, whether it's kind of a liquid diet, in a way they got to get the weight off. That's the first step. And then when they go back to the gym, they have to go back as a 30, 40-something-year-old. They can't go back as an 18-year-old. What that means is no more max lifting, no more trying to lift to failure, lifting respectfully where you're doing things to develop long, lean muscles that support the spine. And so what I say is go back, start lifting, go to physical therapy person, have them watch you and watch you move and develop a program for you. But when you do go back, cut yourself some slack and don't lift to failure anymore. Don't lift max anymore, because what crushes them is usually the squat. If it does come to surgery, the goal is really to decompress that nerve and then stabilize the spine. The decompression of the nerve works great if they have a pinched nerve, 80-90% success rate. Stabilizing the spine, unfortunately, doesn't always equate to great back pain relief, because the surgery in and of itself, putting those big old screws in, as you can see, that's going to hurt. That's going to hurt your muscles long term. Those muscles are never going to be the same after you put that big incision on them. We've tried over the years to do things a little more minimally invasive. And so I think that's helped with blood loss. I think that's helped with decreased hospital stay. I think that's helped with less pain up front. I don't think that necessarily is equated to greater, longer term results in terms of better pain control, less back pain at 6 months, a year. But the way we do it is we put some rods and screws. We drop pedicle screws through the back. It's an incision in the back. And we put the pedicle screws in through the pedicle through the vertebral body. And then we try to lift that vertebral body that's malaligned back up into a better position, lock it down with the rods along the sides, and then a cross link. And then long term, we want to lay down some bone that's taken out from that laminectomy site and get the thing to fuse solid. What it sets people up for is it sets people up for a diminished range of motion, about 2 to 3 degrees per level in the flexibility of the lumbar spine. Turns out L5S1 fusion is really more of a shock disorder, so they don't notice much in terms of flexibility. L4-5 they would. It also sets them up for a long term of beating up that facet complex above their fusion. And so we're climbing up their spine about every 5 to 10 years, it seems like, in some patients that they just beat that facet up and they start to develop instability or a lot of pain at that level too. And that's the thing that we want to avoid. So over the years, as I've lost more hair, I've operated less and less, it turns out, which is pretty consistent with surgeons as they age, I guess, is what I'm told. I used to be really aggressive with these when I first started, and now I'm a little bit more conservative. But the literature would support, as you would expect, that as surgeons we do better if we fuse the spine in terms of outcomes. So who should have a surgery? If it's nerve compression and they're just beating up on that nerve, there's really no other way around it. They've got to get their spine aligned again. Or the people that I've seen beat that a little bit or go back to the gym, lose a ton of weight, and then get their abdominal core strong. Or debilitating pain and relief by non-surgical treatment, or motor weakness. And that's kind of what I reserve it for. So this particular patient, he's still in high school. He's only a junior. I cautioned him against continued play. Especially with loading, so I just, what's your plan here, kid? Are you really going on to play college football? Because if we fuse his back, could we get him back to play? There's not a ton of athletes running around there with fused back playing football. There are some running around with fused necks, which I think is probably a little bit higher risk for at least spinal cord injury, so I'm a little less concerned about returning somebody with a fused back. I wouldn't be adverse to that. But I think that parents and the kid need to be a little realistic about, what are our goals in terms of going forward? Are our goals to get you back to play? Because if that's the case, this might not be the surgery for you. If your goal is to live life better and pain better because it's limiting you, that's reasonable. But at this point, what we're doing is just focusing on abdominal strengthening and then reserving the surgical fusion. I saw him about the beginning of the football season, so probably about 6 months ago now. I haven't seen him back, so we'll see how it goes. Any questions for me?
Yes.
We have till 8:40, so 5 minutes. We're right on time. Yes?
Going back to the slide that you did with your patients, and helping them to get better.
We don't do that well as surgeons. What we rely upon really is to getting them into kind of formal physical therapy, and then injections, and then the very difficult one will offer them that type of biofeedback for the pain psychologist. There's a few people around town that I use. That psychology thing, for whatever reason, is like kryptonite for people. They're very reluctant to have that referral made for them. They're very reluctant to go see them. Of those that actually go, and the ones that actually go are always the workman's compensation group because they have to go, they're forced to go. And those patients universally, usually by and large, will say it's a very positive experience for them in terms of learning coping mechanisms for dealing with pain. And so they do report lesser pain scores if they're willing to do it. What I found is that patients are reluctant to go. But I do mention it, I do offer it. It's like smoking, You tell them to quit smoking and all of a sudden, or lose weight, God forbid you tell them to do either one of those two things. So at some point you have to meet people where they're at, I guess, is maybe the better answer. Any other questions?
When you ask your patients about whether they're experiencing the bladder change,
Yeah, they'll tell you that when they wipe themselves, they're numb. Okay. Yeah, that's the kind of the most easiest way to ask. How do you feel? And so they're numb in around the saddle portion, and so that's where they notice it the most. That and sitting and then going to the bathroom.